Maybe friendly, maybe not. We'll see how things go. These are always can be a little entertaining, we hope too. But so we're going to talk about diverticulitis, and there's a big spectrum of diverticulitis in patient presentation, how it's managed. You look at least the ASCRS guidelines, and they're not terribly helpful because they basically say that the treatment should be dictated based on discussion with the patient, taking into a whole lot of factors. So it's really hard to make blanket statements about this disease because you certainly can't apply them to everyone. So we're going to talk about two things. First of all, we'll start with antibiotics versus observation for acute uncomplicated diverticulitis, and then we'll move on to surgical treatment of diverticulitis, about either doing a Hartmann's procedure versus anastomosis and proximal diversion for emergent diverticulitis cases. So to start off, we have for the antibiotics versus observation, we have Dr. Stephen Shapiro from Gunderson Health System and Dr. Annabelle Barber from UNLV. And so Dr. Shapiro, you're going to start and tell us why we should be using antibiotics.
Okay. Well, thank you very much. I have the assignment of talking about antibiotics for acute uncomplicated diverticulitis. And if there ever was a benefit of CME education, this would be one to pay attention to. Uncomplicated diverticulitis is a situation that surgeons do not see that often. Presents with abdominal pain, anorexia, fevers, leukocytosis. You have pericolonic inflammation, thickened colonic wall, which you see on these CT scans. And most importantly, there's an absence of complexity, absence of bowel perforation, no abscess, no phlegma, no fistula, no bleeding. Millions of people have diverticulosis. Incidence increases with age. We know that it's older person disease, with over 70% of people having this process of age 80 or above. Rarely requires hospitalization. A handful of people get recurrences, and rarely do people develop complications. So this is typically a mild, uncomplicated diverticulitis. So I want to set the stage. It's different than your night on call. So I'm going to argue that antibiotics have a role in acute uncomplicated diverticulitis. These are the antibiotics we typically would use: Augmentin, oral, ciproflagyl, ceftriaxone. If you make it to the hospital, you might see some Zosyn. And we all know that our patients get better with antibiotic administration, because we were taught that the outpouchings of the sigmoid colon, where the stool ball causes microperforation and bacteria-rich stool from the colon leaks out and is contained by the appendices epiploica. And we were all explained that the appendices epiploica are most thick and most prolific in the sigmoid colon, where diverticulosis and diverticulitis happens. It's kind of the patch that saves the patient. And when they rupture, you can get resolution, abscess, or free ruptures. And in this storyline, antibiotics killed the offending bacteria, and we know that patients get better with antibiotics. And this is not crazy, because we were taught in our textbooks. Sabiston therapy consisted of bowel rest, IV antibiotics, the Merck manual, which is read by family practitioners and internal medicine docs, bed rest, nothing per mouth, IV fluids, antibiotics. Cameron talked about IV antibiotics, and Schwartz principle of surgery, which I believe my opponent has written in, has patients with minimum symptoms or signs of inflammation can be treated on an outpatient basis with broad spectrum antibiotics for a week or so. So when I got the task of speaking about antibiotics for uncomplicated diverticulitis, I was pretty happy. I went, boy, this is really going to be great. And I started looking at the literature a bit. And then at some point, I realized that I had pretty much been screwed. Because there are papers favoring no antibiotics for uncomplicated diverticulitis from around the world. The Dutch trial, I believe the Scandinavians got involved. Cochrane has a very thick review. Australia, New Zealand got involved, not just a little way, but a double-blinded randomized controlled trial. Current problems in surgery provided no support for me. The American Gastrologic Association was against antibiotics. New England Journal of Medicine, the family practice docs, the Mayo Clinic, and even Up to Date offered no support. And my opponent will probably show many pictures like this of equivalent observation versus antibiotics. So here we go. This is a gun to a knife fight. And I want to talk about the modern papers favoring antibiotics for acute uncomplicated diverticulitis. And this is what I found. But if you dig deeper, you find some exceptions. And there are really good indications for antibiotics in uncomplicated disease. And it depends a lot on patient factors and how they're doing. So again, this is the pro antibiotics. And I want you to pay attention that patients with comorbidities who are frail tend to get recommendations. Immunosuppressed patients, patients with elevated inflammatory markers, white count over 15,000, all complicated cases, refractory cases, malnutrition, diabetes, HIV, congestive heart failure, hepatic impairment. So now we're starting to get what we see in the ER. Pregnant patients, kidney disease, colon vascular disease, corticosteroids, septic patients, altered sensorium, chills, rigors, tachycardia. So all of these papers that argue against antibiotics have these little exception clauses. Comorbidity again, inflammatory bowel disease, immunocompromised, another inflammatory marker of sepsis, positive blood cultures. So I want to talk a little bit about when you don't have much to talk about with your subject, you change the subject. So I'm going to talk about complicated disease because I don't want you leaving here thinking that antibiotics have no role in diverticular disease. So these are the Hinchy classifications, the pericolonic, the pelvic abscess, the leakage of air, and the leakage of stool. So these people all get antibiotics. This patient on the right was one I picked up last week from call. This person got antibiotics. When you perforate your colon, it's a mixed flora. E. coli, Clostridium, gram-negative anaerobes, all those type of bacteria are leaking out. And we do recommend some antibiotics. Here are some society recommendations for broad spectrum, ciproflagyl. These are essentially the antibiotics I showed you on the slide beforehand. So antibiotics do have a role in diverticular disease in select cases, and the pendulum has swung quite a bit. And this is a pretty nice setup for my opponent here to come up and talk about the recent literature.
Thank you very much. Dr. Barber, your turn.
Well, it's very nice to get the softball in. Thank you. Really, I'm advanced screen. I'll probably be at the end of the talk. Yeah, probably did so many forwards. Yeah. Here we go. So uncomplicated diverticulitis is, again, what we don't see. We don't see these so much because they are at our colleagues' door. And we often have, since in our hospital, everyone gets the fourth vital sign in the emergency room. That is that they get, my goodness. I think I've gone through my entire slide by trying to get there. Backwards here. I apologize. This is for anybody that does hungover still and get everything twice. And so you'll see, there will not be a test to get CME. So, all right. Here we are. Well, I do want to start out. We have taught and learned that this was an infectious process that, as I've been set up so nicely by my opponent, that we thought that, well, we have all this bacteria that we get a little bit of. I did tons and tons of work on bacterial translocation, and we may not have an abscess, but it is a whole bacterial problem that we're trying to treat. And so, yes, of course, we'll give these antibiotics. You know, we always say, won't hurt, might help, always a crowd pleaser. And so this is, you know, a Gomer, get this person out of my emergency room sort of treatment. So this is what we always did, and it seemed to work pretty well. And I would submit to us to think about this Dr. Capps has so nicely set us up as well in her talk of stop and listen and look at what's really going on, because and not just accept the dogma that we're going. And I would submit that our patients have gotten better not because of the antibiotic, but they in spite of the antibiotic treatment that they got. So that was something that why should we look at it? It worked. So what were we fixing? A problem that wasn't there. But we think, well, how do we have, I was lucky to have my 50th birthday present, my colonoscopy, to find out that I assumed I probably had diverticulitis just like everybody else. I was just delighted to know that I did not have any. And so really, since it didn't affect me, what was important, you know? And so we think about what is the pathophysiology of really why do some people get diverticula and others don't. And so this has been studied in great detail in that there seems to be a process of fibrosis and actually nerve degeneration and alterations of the collagen and the way we make ourselves and remake ourselves every day. And that some disturbances of the metalloproteinases and some inflammatory things cause these little pockets going on. So this is dysregulated for a variety of reasons. And so some people are more prone to get diverticular and some aren't. And so these things all come together to show that the longitudinal muscles sort of degenerate and relax, and with a sort of a dysmotility of the sigmoid colon that leads to the development of diverticula. So it's not something, though common, we say 70%, we're taught 70% of people over 70 have diverticula, but it's not necessarily a known thing, a guaranteed thing. And perhaps we do know that people in Western high meat eating, less vegetable eating cultures have much more diverticulosis and diverticulitis. So we may be able to have these maybe modifiable risk factors that we can act in earlier. Not everybody has to have it. We know that this inflammatory portion of this, that we have pro-inflammatory cytokines that are even in relatively asymptomatic or even symptomatic diverticular disease, that you can measure increases in inflammatory markers, that you get increases in IL-10 that has not been studied as much as the IL-1, IL-6, and IL-2 and all the TNF, the pro-inflammatory markers, but we do know that IL-10 can be greatly increased with a episode of inflammatory diverticulitis. And there are some hints in people that have collagen diseases such as Ehlers-Danlos, Marfan's, and that do have a propensity for developing diverticulitis. And there are other genomic alterations that are really, when I read as not a geneticist, just have alterations in a lot of base pairs that probably, as the genetic research is moving so quickly, we'll probably be able to identify populations that really are at risk for diverticulitis and that may be at modifiable risk. But that's sort of where we are right now in that, to us non-100% scientists. So we know that from again, I had a great setup to get this off things, that in a number of studies, and even those BC, that's before COVID now, we have to really change the way we think about this. In the BC Times in 2018, these the Avoid and Diablo trials show both that the rates of recurrence, complications, or eventual surgery were no difference with or without antibiotics. And this is in uncomplicated diverticulitis. So, and then even in the long-term follow-up of these, people are very good, and they got 11-year data on the same population and really showed the same thing. Why they really wanted you to get the 11-year data was in the initial one, the the no antibiotic group had a greater propensity to eventually have sigmoidectomy, but then that really wasn't borne out on further study 11 years later. So that is really good data, and so we can probably maybe pass the frailty index with Dr. Capsule let us. And so then we know that this has been borne out over and over again. And so I think we don't need to repeat those trials. Again, where this is, like I said, for all the people that are still asleep, because you get the same data again, that even though I got the softball thing, but I can still say that in agreement with my opponent, that the people who do need antibiotics and the exceptions to the no antibiotic rule are the immunocompromised patients. And we think of, you have to think of pregnancy. For some of the students and residents may not always think of pregnancy, but pregnancy is an immunocompromised state, so you don't reject your baby. And chronic kidney disease and collagen vascular disease and chronic corticosteroid use and sepsis are all immunocompromised states. So those people, if you have someone that has concomitant diverticulitis, then you should give those people antibiotics. And we know that these things, if you do not do that, then these patients don't do as well. So that's really what I have to say. Thank you.
All right, Dr. Shapiro, you have a couple minutes for rebuttal.
Yeah, I've got a couple slides prepared. If you could pull the cactus slide back up and go to the slideshow up. This is all part of my ploy to use my 3 minutes. All right. So what I'm going to say at the end as I continue to work in the role of pro-antibiotics is the treatment of uncomplicated acute diverticulitis is certainly evolving, and it has evolved over my career. Our basic science as described is evolving, and we know it's more of an inflammatory process than an infection. And antibiotics were used to be the preferred treatment, but the current recommendations favor selective antibiotics in aseptic patients, comorbid and frail, immunosuppressed and pregnant. And we should continue to use antibiotics in complicated cases of diverticulitis. And that's the meat of the pro argument. Because you're going to continue to still use antibiotics when you get back to your practice, I just wanted to make sure you had some other ways of saying yes to giving them. So that's my conclusion.
Dr. Barber, further comments?
I have just a few further comments, but I would ask everyone to look at their patients to make sure that they do not have complicated diverticulitis, because I think there are subtle ways that we need to kind of continue to study because we do not know what the trigger for what the people with uncomplicated diverticulitis go on to have complicated diverticulitis. And I think these are areas that we all want to participate in finding out more about and finding out the populations who are at risk and what are the modifiable factors. There are some interesting studies being done using anti-inflammatories, and I would encourage everyone to help us educate our fellow physicians and our patients in trying to get to the bottom of this disease, and so that we can really figure out better understanding of how to prevent recurrence and how to prevent the people from going on to have complicated and need our services as surgeons. And so I think that that's what my thing is, just to don't give antibiotics, but let's try to participate in the trials, giving anti-inflammatories and sort of the ways and how can we modify our things. Happy to see that we have healthy food as choices and all our breaks and everything. And so if we can continue to do that, it'd be wonderful. Thank you.
Okay, so now that that's settled, we'll get into surgical management. So we have pro and con of doing a Hartman's procedure at an initial operation versus anastomosis and proximal diversion. So in the you should do a Hartman's camp, we have Paul Bjordhal from Stanford Health in Sioux Falls, South Dakota. And then talking about against the Hartman's procedure is Yosef Nasseri from Cedar Sinai. Dr. Bjordhal.
All right, well, thank you and appreciate the opportunity to participate in today's debate where I really need to convince a room full of surgeons that you're already doing the right thing with our Hartman's procedure. So if cases admitted to the hospital with diverticulitis, around 20% of cases are operative at some point during that acute time. Those are due to peritonitis, due to septic shock, due to acute obstruction. And so really when we're talking about whether or not we do a Hartman's procedure or a primary anastomosis, that's a life-saving intervention. This is not the antibiotics versus none discussion. These are all patients that need to be on antibiotics. Diverticulitis in general, but even operative diverticulitis has a wide spectrum of disease and local inflammatory severity. And we've all seen that when you get in there, sometimes you say, that's not so bad. And sometimes you're just hoping you can get back out. So, and resection, a sigmoidectomy for diverticulitis is generally the gold standard for source control. So really today, we're going to shift the conversation. We are talking about acute sigmoid diverticulitis. We're talking about severe disease, patients in sepsis, and they need something urgent and life-saving for the resectional operation. We're talking about patients, hopefully only for whom diversion is indicated, either with a Hartman's or a primary anastomosis with a diverting stoma. Okay. So again, we're not talking about the stable patient who never needed diversion in the first place. The disease is milder than expected when you get there. Or we're not talking about patients who get a primary anastomosis and they don't need that diverting loop. We're not talking about people who would get the laparoscopic lavage or just percutaneous management or anything else. And we're not talking about elective delayed resections. So again, I've got to sell a group of surgeons on why a Hartman's procedure. So it's definitive source control. There's no anastomosis. There's no anastomosis to leak. Okay? It has a lower operative time for that sick patient who doesn't really need to have all their time spent in the operating room. And should it be such an ill patient who's not going to be a candidate for reversal, it has a better quality of life than ileostomy. Okay. It's the choice of surgeons. Annals of Surgery 2019, or excuse me, this is JACS 2019. They looked at 4 years of NSQIP data. Patients getting Hartman's, patient getting proximal diversion with their primary anastomosis. 93% of the time, surgeons were doing a Hartman's procedure on diverticulitis. Yet, even with such a hugely weighted selected population, they said, well, I mean, primary anastomosis, the diverting stoma, is a safe alternative for certain patient populations. And that's a highly selected patient population at only 7%. Okay. Highlighted the need for randomized control trials on this topic, of which there are a few. Okay. These studies are all European. They're done prospectively with an intention to treat basis. They have the inherent limitations that go along, even with a really well done study. It's hard to assess the severity of that pelvis preoperatively until you get in there and they've already been randomized. Emergency surgery trials inherently are going to exclude the most ill patients who can't consent in the first place, or the surgeons will opt to not enroll their patient because they're too sick to consider anastomosis. Crossover is typically one way. If you go into a trial, you intend to do an anastomosis and you abort, you're always going to switch to a Hartman's, but nobody's too sick for a Hartman's. And then again, the surgeon's judgment is going to supersede that randomization and that enrollment. A couple examples of these. First is in 2012, Annals of Surgery, European trial, and they randomized 62 patients. There's no difference in mortality. There's no major difference in complications. The index operation for Hartman's is an hour faster. The stoma takedown is easier in a loop ileostomy, which we all knew. And again, a very selected population. More than half of the screened patients weren't enrolled. Most of those patients went straight to a Hartman's instead of being enrolled in the trial. Even 10% of the patients who were assigned to get a primary anastomosis got a Hartman's. and were still analyzed as a primary anastomosis. Similarly, I think my opponent will probably look at some of these same trials and cite some of the same data. The Diverti trial in 2017, same thing, about 50-50 Hartman's versus primary anastomosis. Similar mortality, Hartman's is an hour faster. Ileostomies are easier to take down than a colostomy, as my opponent pointed out yesterday, actually, with their paper. They excluded septic shock. They excluded multi-organ failure. 10% of the primary anastomosis group got a Hartman's. So of the 45 patients who underwent a primary anastomosis, a third of them weren't even diverted. And yet still analyzed on an intent to treat basis. Additionally, you look at their demographics, 14% of these patients were ASA1, as opposed to the NISQIP paper had 1%. So again, highly selected, probably overly healthy population. And if we're overoperating, you're going to find that you're creating worse results. The ladies trial 2019, again, another European trial. This is initially enrollment was done for a laparoscopic peritoneal lavage, but those terminated due to worse outcomes. They took the same enrollment patients and randomized them to Hartman's versus primary anastomosis. And again, similar mortality, similar complications, and really their primary endpoint that they reported on was the rate of stoma takedown and stoma-free survival. Again, 10% of your primary anastomosis patients get a Hartman's because they were too challenging and it wasn't safe to anastomose. A third of the patients who had primary anastomosis, again, had no stoma. This is not the same disease we're talking about for a Hartman's. Okay. So really, and the enrollment really kind of skewed it from the start because this is a study based on patients who were thought to be appropriate for maybe just a laparoscopic lavage and no resection in the first place. Okay. It's also done on an intent to treat basis, where when they show their curve for stoma-free survival, the blue curve being primary anastomosis, you can see on day 0, they've got a head start. A third of them don't have a stoma. So if you just take that and shift it, and I apologize, this is the best I do when I'm moving the line, those really end up extremely similar. Red line superimposed over blue, if you can see that. And so by the 1-year mark, the stoma-free survival is essentially the same. Okay. So when we look at the data that's out there, what we've learned, we've really confirmed ileostomies are easier to take down than colostomies. We already knew that. Not all patients are appropriate for consideration of an anastomosis, and that's what the surgeons demonstrated with their judgment in these studies. They excluded patients and they over-enrolled the healthier patients to compare them. And even when they're enrolled for those trials, the Hartman's patients perform similarly as far as survival and complications. So we have to keep in mind, diverticulitis is a broad spectrum of disease, even when it's complicated. You're going to have to patient selection is going to be very careful before you consider doing an anastomosis. And that's why more surgeons are choosing the Hartman's for the most severe diverticulitis, even when they intend for a primary anastomosis. And so really it's about what can you trust with your operation? What do most surgeons choose? I mean, surgeons relied heavily on a Hartman's for severe complicated diverticulitis, shown by the NISQIP data and by the randomized controlled trial crossover data and their exclusions. So really, I'm telling you information that we already knew and all those surgeons already knew. And so that's why it's my job to encourage everyone that you should trust the operation that more doctors trust than any other operation for severe complicated diverticulitis. Thank you.
Dr. Nasseri.
We click forward. The green one?
Yeah, green forward.
Perfect. Good morning, guys. Let's spice it up a bit. Let's spice it up. My name is Yosef Nasseri. I am a colorectal surgeon practicing out of Los Angeles. I did get some help from a couple of my students. I want to give them credit to help me with a couple of the slides. So as you could tell, I am a fellow of the American College of Surgeons, but also a fellow of the American Society of Colon and Rectal Surgeons, and that's going to come into play later on. So keep that in the back of your mind. So what are we arguing today? This versus that. And I'm going to encourage you to be forward thinking. Let's change the dogma. We just have to take that leap to change our practice to be forward thinking and not to be short-sighted. So I say no to Hartmann's. And you'll see that I'm going to present to you an undisputable argument that the way forward is putting the bowel together and just giving the patient a simple loop ileostomy. So let's dive into the data. Now, this data I'm going to present, we selected out the grade 1A data. I mean, this is the cream of the crop. When we talk about data and how we change our practice, these are the studies that we rely on, right? So this is the study from Annals of Surgery, 2012, multi-center, randomized clinical trial that included both Hinchy 3 and 4. About a quarter of the patients were Hinchy 4 patients. Hinchy 4 means, by the way, there's feculent peritonitis. There's stool roaming around. And you'll see that there was such stark difference in outcome that they had to continue the study, stop the study short. You know, the stoma reversal rate was almost double in the primary anastomosis group. The complications were way higher in the Hartmann's group. Operative time over here is shown to be shorter, length of stay, and cost. Everything was favoring primary anastomosis, so much so they had to cut the study short. Let's move forward. Another high-level study, prospective multicenter. This is the Diverti, which you were referring to as well. Higher number of patients, still included a good number of Hinchy 4 patients. You see, the recurrent theme is this, is the fact that nearly all patients who had a diverting loop ileostomy had their ileostomy reversed. It's not just that it's easier to do. The question is it going to happen? Are you rendering the patient to a long-term lifelong colostomy, or are you going to let them go back to a normal life? So study after study shows that the loop ileostomy allows you in almost 100% of the cases to go back to live a stoma-free life. Another one, multi-center, parallel group, randomized open label superiority trial. About 130 patients, good number, about a third of them were Hinchy 4. Again, almost nearly all patients were stoma-free about 12 months out in the primary anastomosis group. And we see over and over again that only about 2/3 of the patients had their ostomy close in the Hartmann's group. And in real life, the percentages are even lower for the Hartmann's. So this is a meta-analysis kind of pulling all the data together. You know, this is published recently in 2020. 4 randomized controlled trials were included, but a cohort of multiple other studies. And the recurring theme is the stoma reversal rate was more than 2.5 times in the primary anastomosis. But this one also points out, look ahead. The colostomy closure is a morbid operation. It's not a bread and butter operation. It's not a colectomy. That operation sometimes renders you with another ileostomy that you have to close down the line, right? So, in fact, my brilliant student presented our data on this podium. You know, we got an oral presentation for it. Shows that, yes, we know ileostomy closures are simpler, but let's pick it up. Let's compare Hartmann's closure to a colectomy. You know, it's a more complex operation, a more common operation. And we see that even compared to a left colectomy, the Hartmann's procedures is more likely to be done in an open manner, that has longer operative time, has a likelihood of having another ostomy. Overall complications rates are high, and there's increased length of stay. See, the way to think about this is you have to think it's a continuum of disease. You can't think of tonight I'm waking up to give this patient Hartmann's versus primary. Think ahead. It's a continuum of disease. You got to take the next operation and the next operation in mind. So do not be short-sighted. This is not a one-time hit. It's not a one, let's wake up, let's get, I got to get back to bed. You get back to bed, yes, the operation is shorter to the Hartmann's, but if you spend that extra 45 minutes, you're going to save a whole lot of pain to the patient, You're not going to render him with a permanent colostomy. And ultimately, you're going to have a less morbid operation later on. So it boils down to this. What's better down the line, ileostomy closure or colostomy? It's easier operation to close an ileostomy. It's a shorter operation. It's less than an hour. And the bottom line is the most important. It's not just it's easier, it's going to happen. Versus with the colostomy closure, there's a very good chance it won't happen ever. So here's my opponent. Nice guy, but you trust this guy. He advertises himself as a trauma and critical care physician. Only 16.7% of his practice is dedicated to colorectal. And now if you look to the right of the slide, he only works between 8 a.m. and 5 p.m. When does he do these Hartmann's closures? You know, he's the kind of person that does the Hartmann's and then sends them over to me, to a colorectal surgeon, to close them. So he may tell you that I have a boutique practice in Beverly Hills. I mean, last time I looked, Sioux Falls, Dakota has a population of 177,000. And Los Angeles has a population of nearly 4 million. So we see them all. We see them tall, short, obese, thin, we see them all. And you may say that, how can you put a bowel together in a soup of poop? And you're right, it's not for every case. It's not for the hemodynamically unstable patient, and it's not for someone who is sitting in a soup of poop. But you'll be surprised that the bulk of the patient, you could put them together. So take your pick. Do you want to be the patient to the left, or do you want to have your patient to be the one on the right and ultimately have that closed? I'll let you decide.
Go ahead, my slides back, please. No, thank you. And I completely agree. It's a total spectrum of disease. And that's what we're here talking about is the Hartmann's procedure a reliable operation for that septic patient? And so I pointed out the flaws. I like that we both talked about the exact same studies and the enrollment issues that you overlooked while citing that data. But for those cherry-picked patients, that's a great way to go. And so I had an opportunity. This is really a difference of the lenses we're looking through. I work as an acute care surgeon primarily, and so when these dying patients come in the middle of the night, because they come in before they call your office once the office opens the next morning. And if the patient's well enough to pick up the phone, call you, ask you to come over, and you can, call your Beverly Hills boutique colorectal surgery office. They pull it up, they get on their smartphone, they find the website, and they say, hey, there's a diverticulitis specialist. And you look on the page, and sure enough, right, he treats diverticulitis. That's fantastic. You zoom in a little closer on there. Is this the patient you think we're talking about? This out of work 25-year-old actor? When we're looking at the life-saving intervention, a Hartmann's procedure is always going to be in your back pocket as that ill patient who needs to get out of the operating room, the multi-organ failure. And so full disclosure, I do, for the most part, primary anastomosis. I completely agree. But this is a case where for diverticulitis, for the most severe patients, then Hartmann's is just in our back pocket. So I do feel like I walked in a little bit at a disadvantage because this is not what I do mostly. I probably 4-to-1 hook them back up similarly. But there's a great spectrum that goes in there. So.
See, I have no slides because I've already predicted everything you're going to say. I'll just end it like this. In the name of the great Vic Fazio. Vic Fazio always said what differentiates a great surgeon from just a good surgeon is one that looks ahead later on. What's going to happen in the next operation? You don't want to make this operation to go easier. You got to look ahead. when you form a pouch for a ulcerative colitis patient. You got to think, are you going to have enough reach? Are you going to be able to perform the next operation? So Vic Fazio was a visionary. Obviously, he changed the way we practice a lot of things. So in honor of him, I encourage you, again, don't be short-sighted. Look ahead. Do not, living with a colostomy sucks. And if you could shorten that time, that goes, that goes such a long way. You don't want to have a third of it. I mean, it sounds like statistics to us, but having someone restore their confidence, their way of life, and closing that colostomy, it's not just closing a colostomy and living without it, is the complications that arise from a colostomy closure are just immeasurable. It's one of the toughest operations. I think the reason I focus my research on it, it's one of the most underestimated operations in colorectal surgery. Closure of a Hartmann's. And so yes, take that extra time. You're right. Most of us do the Hartmann's procedure. In fact, I do them also. But I think it takes us to kind of push ourselves an extra 45 minutes to save a whole lot of pain for us and for the patient down the line. Thank you.
All right, so I think in the interest of time, we will forego questions so we don't run into our next session. But I'd like to thank the panel for their participation, excellent points, and really appreciate all your work. And we do have another note up here to remind everybody during the breaks, please take a little time to go visit our industry partners in the exhibit hall.